For those who don't know me, I'm Charlie Wells. I'm the founder, CEO of HelloSelf. And part of the reason why we're holding this event today, we do lots of CPD sessions, but it's actually a very big day for us. So when I founded HelloSelf with Dr. Amina Taylor, we really wanted to understand how we could deliver personalized psychological advice to everyone. We wanted to make yourself better, every self better. And we started off building a kind of platform for therapists to deliver better outcomes. Our platform delivers about 40 outcomes, about 40% faster. But we also wanted to build a product for members so they could proactively look after themselves during treatment, and obviously a part of the product for our referrers, so we can work with the NHS, we work with insurers, we work with private psychiatrists, private GPs, lots of whom are on this call this evening or watching the video. So thank you for your support. And it's been amazing that we've grown a community of over 300 clinical psychologists and counseling psychologists giving treatment every week, but a community of actually approaching sort of 900, 850 odd therapists within our ecosystem. But we've always been adult only on the platform for a number of good reasons we'll talk about today. That when you get under 18, there's a lot more kind of systems thinking, there's a lot more kind of care structures and risk structures you need to put in place. About a year ago, we started looking at doing CAMHS off platform. So not many people know, but we actually have 2 locations where we do assessments and treatment, where we could kind of manage the risk, and we could manage our members with a sort of white glove service. And then about 6 months ago, we started working out how could we get the platform ready for CAMHS. And the exciting announcement is today is our first day of opening the doors to platform first CAMHS. Obviously, we've had a number of people go through that, and our outcomes are sort of pleasing. Our clinical excellence and risk team have gone through the whole product. We've changed some of the features to make them appropriate for CAMHS work. We've passed new levels of pen testing, which is testing the technology, as well as making sure the permission structures are in the place. So we're super excited to open up that platform now for all sorts of referrers. So we're now doing that with 2 of our big insurance partners, including Bupa, who we started working with a couple of days ago, and AXA. So thank you for your support, as well as all of the psychiatrists and trusts that we work with. So this is a really exciting moment for us. We're going below 18. We're starting off at 13 plus, but this is obviously a huge step forwards to Ramina and I's vision of like, how do we ensure that everyone can get personalized psychological advice, not just arbitrarily drawing a line at 18 and saying, you get it and you guys don't. But we've learned a lot along the way, and a special thank you goes out to Louise and Pelumi, who's on our panel today, who've been leading our thinking on how do we do CAMHS in a super safe but effective way. We wanted to ensure that we didn't just deliver a gold standard service, but that we actually kind of stuck to our values of making sure that we could try and get people better faster and then keep them better longer. So how do we make sure treatment is really effective and people do their homework, they remember and practice what happens in treatment, and then that they can stay well and reduce relapse post-treatment. So we've got all of those things in place for our CAM services. But of course, the biggest feature that we have been championing for about a few years now is connected care. Like, how do we ensure that the clinician has other people in the kind of care team around them that make sure they can deliver better outcomes? And we've shown over and over again that when a clinician works with a psychiatrist or a family member, the member gets better faster. So connected care works. And we really want to embrace that in our kind of CAMHS solution. So exciting times. If you're interested, if you're a CAMHS therapist, if you're a CAMHS clinical psychologist, if you're a CAMHS psychiatrist, if you're an NHS trust, if you're an insurer, whoever you might be, if you're interested in CAMHS, please do get in touch with the team and we can talk you through how it works and how you might be able to partner with us. That's the only sales bit. So there we are. That's my kind of sponsored by HelloSelf bit. The rest of the evening, I will be an entirely neutral host. So we're going to talk today, as I said, about how do we build these interdisciplinary teams around young people's mental health in order to deliver better outcomes. So I'm all interested in that. Like, we need great experiences, great outcomes, and we need people to get better faster. And I've got the most perfect panel to join us today. So I'll let them introduce themselves, but I'll do the sort of short version. We've got Daniel, who's joining us, who is an educational psychologist. We've got Victoria, who is actually doing lots of stuff in kids' mental health, but originally was a nurse. We've got Emma, who's also from an amazing organization called Stormbreak, who was originally a social worker. We have Dr. Billy, who's our medic, who will talk about diabetes and kids. And then we have Pelumi, who representing HelloSelf, who's our counselling psychologist, who's been working with Louise, who's our kind of director of clinical excellence, to make sure we have a an appropriate platform for CAMHS work. So we have all sorts of different backgrounds and training. It's an interdisciplinary panel, but with lots of different expertise. So I'm going to let them introduce themselves, and then we'll jump into the conversation. Shall we start off? Oh, I didn't think about order. I'll do it in order on my screen. Daniel, do you want to kick us off and say hello?
Hello, I'm Daniel Sobel. My background, I did a master's in education psychology and also in psychotherapy. My doctorate was in education, however, and I practiced as a Senko for about 10 years. I wrote some books which became well known in education, I suppose. I speak around a lot, and I set up an organization supporting the development of inclusive practices in schools, which is in 130 countries, and we're partnered with the United Nations, UNESCO, and so forth. I also run a master's program in inclusive educational leadership, sort of helping convert the Senko training into a master's level training. So I know something about the Senkos, and I'm here today in the capacity of Senko as someone who knows something about Senkos.
Perfect, thank you. Welcome to the panel, Daniel. Victoria, would you like to introduce yourself?
Thanks, Charlie. Hello, I'm Victoria Stamp, and as Charlie said earlier, I'm a registered children's nurse. My background of 25 years working in the NHS before I joined Stormbreak. I've worked in community care, I've worked in schools, paediatric departments, CAMHS. I've always had a passion for emotional well-being in childhood and helping children to thrive and not just survive adversity when there's a physical health need. A couple of years ago, I made the move to become the mental health lead at Stormbreak, which is a national children's mental health charity. And we are all about prevention at scale, so helping children to thrive through mentally healthy movement. And I'm also studying in my spare time for a master's in applied positive psychology and coaching psychology.
Thank you, Victoria. I love the fact you have spare time. That I suspect you're fitting lots of stuff on top of each other late into the evening. And I'm not meant to do plugs, but for those who are interested in hearing a lot more about Stormbreak, we've just released a podcast episode with the founder of Stormbreak, Martin Yelling. So look up for the Hello Self podcast. It's called Self Matters, and you can find out a good hour of content about the amazing work they're doing there. But another great Stormbreaker is Emma. So Emma, could you like to introduce yourself? And
Thanks, Charlie. Yes, my name's Emma Dowinton. I'm a social worker. I qualified in 2003 with a master's in social work studies and have continued to do postgraduate studies since then. My social work career has been all within children and families, working within child protection, fostering, family support, and working with asylum-seeking children. I still continue to work as a social worker in the local authority for 3 days a week, but I'm very blessed to be able to work for Stormbreak now as a consultant social worker for 2 days a week. So I think this evening I'm going to be coming to the table really with two hats on. I think it's really important to know that I'll be talking from my social work local authority hat, as well as working with Stormbreak and the preventative work we do. So that's me.
Great, thank you for joining us, Emma. Billy, Dr. Billy.
Oh gosh, I'm Billy White. I'm a paediatrician. I lead the severe obesity service at Great Ormond Street. So it's a regional service helping families who are struggling with excess weight. And as you can imagine, there's multiple components that go into being able to live a healthy lifestyle. And we provide a holistic service to try and support some of those many needs. And I also am the lead paediatrician at the diabetes service at UCLH. So lots of chronic disease management. And as we know, looking after a chronic disease is hard work. It comes with lots of comorbidities. It's not nice being a teenager with a chronic condition. You want to be like everyone else. So I think this is a good setting to see what sort of offer Hello Self has got, what's on offer, and to hear from other professionals, think about how we can all work together to support young people.
It's great to have you. Like, we've done a couple of events in the past where we've looked at sort of health psychology and how psychologists can support people get better when they've gone through a kind of health conditions. We do a lot of work with oncologists, etc. What we haven't yet is explored that kind of health and CAMHS and interdisciplinary work. It's going to be a really interesting overlap to hear your experiences. Thank you for joining us. Pelumi, do you want to introduce yourself?
Yes, of course. So yeah, my name's Pelumi. I'm a counselor and psychologist by training, and I'm also a dad of two. I always like to, yeah, put that in. And yeah, I've got a 3 and a 4-year-old. Um, I'm also the clinical manager here at Hello South. I work very closely with the customer success team, helping to make sure that our members have a good sort of experience in terms of coming through to the service. One of the things I'm doing at the moment, which is one reason I'm here, is because I'm working very closely with Dr. Louise Egan, who is our director of clinical excellence and safeguarding, and also helping to develop our CAMHS service. And by the way, Dr. Louise does send her apologies as well. She wishes she could. Well, she would have liked to have been here. In terms of my clinical experience, the majority of my experience is actually working with adults in the community. Although I do have, I've spent a number of years also working with, working in CAMHS services in Tier 3 and Tier 4 CAMHS services. My research sort of specialist area was in eating disorders. I looked at eating disorders in adolescents and the recovery process. So yeah, I've always had a bit of an interest in CAMHS and young people. But yeah, thanks for having me.
Well, thank you for joining us, Pelumi. It's going to be strange. Like, we're going to interview each other. Like, I'm trying to be neutral and not let everyone know that we know each other. But for transparency, obviously, Pelumi and I work with each other. Great. Well, thank you for my introductions. As I said, please put questions in throughout. I'm not a rule keeper, so I will probably break the structure. But if you put questions out, they will get kind of fed through to my my little iPad here. So if I'm looking down, looking like I'm distracted, it's not because I'm bored. It's because I'm reading the questions. But we've kind of got sort of 5 big themes that we really want to go through. So we've got a bit of a structure, almost kind of going through the kind of pathway of how we think about treating people who are under 18 years old. And so I really wanted to kind of start off thinking about, what can we do to do more kind of early intervention or prevention? Like we always jump straight into like what's treatment, but I think, what can we do that's kind of upstream of treatment? Because there's so much that can be done in an interdisciplinary way in the prevention in early years. So potentially I can ask the team, and maybe I can ask Victoria first. Like, are there any, in your experience, any sort of early indicators that can help us understand how do we target early intervention amongst CAMHS?
Yeah, so I think any adult that's worked in a childhood setting would be able to describe or think about a child who's sticking their head above the parapet and letting them, through their behavior, that they are beginning to struggle with really big feelings. From when I've worked in CAMHS and other areas, I used to run a emotional support service for children with lifelong, life-limiting and life-threatening conditions. And one of the things that were really common features was helping the adults around the children to understand emotional literacy, helping the adults to coach the children with their emotional responses. So I think that emotional literacy is the very first step, helping children to grow up with an awareness of what feelings are, what they mean, and how you can respond to them. And you don't have to just get carried away with the wave of them. You can respond. So I think that's kind of, you've got the behaviors that you'd see, and then what do? You just coach them through it. You help them understand what is going on in their body.
And does anyone else? I guess Dr. Billy, like from a medical point of view, presumably you've got people coming into hospital already with a kind of a medical condition. Are there any early indicators you can see that could have been sort of psychological interventions earlier in that child's journey?
Not so much from coming into hospital, but a lot of the work we're doing is about thinking about why we eat and why we feed our children and how we feed our children. And what is often striking to me is how people don't think of weight and weight trajectory as a warning sign that something's amiss. And they just don't think about the implications of it. So, a kid who's been a similar weight for ages, who's suddenly putting on lots of weight at school, and the teachers, they go, oh, he's put on weight, but they don't really know how to tackle it. And they're thinking, what is going on? What's the new stresses? What's happened? What's changed in this family's life that suddenly this kid's weight trajectory is suddenly shifted? And like, you know, we're pretty good at, on the whole, at noticing people weight loss and then raising concern about weight loss, but not so good at weight gain, because I think it's quite hard to, it's a difficult discussion to have. It's potentially awkward discussion to have, but people don't see it as a warning sign that something can be amiss. So yeah, so that's something that we do lots of work with, thinking about eating, what that means, feeding, why parents feed their kids, how they feed them, respond, you know, why we feel hungry.
Yeah, no, I think we've already, Victoria kind of touched upon, you know, you can see kids going through big emotions, right? They've got to try and help them understand that. And obviously people's weights changing, their size are changing. But this happens when you're a teenager all the time. Like, emotions are really big as a teenager. Like, I got fat, then thin, then tall, then all sorts of things. There's so much change going on. How do you notice what's kind of normal kind of kids' teenagerness versus what is something that needs an intervention? I mean, maybe well, no, sorry. If we, Emma, like, as a social worker, that surely is your kind of craft in trying to understand when do you need to do early intervention.
Yeah, absolutely. And I think in my role working with children in care at the moment, these children have all had such adverse childhood experiences. They've already experienced trauma and loss, and they have been taken from their homes. But the issue we have a lot is that preventative work, often we're told we can't do that yet because these children aren't in a stable placement. You know, they might have moved around a lot. They need to be in that stable place in order to receive support. And often these children will never be in a stable placement or somewhere where they feel safe. And that's a real barrier we have, certainly as a social worker, is that we need to, the indicators are there straight away. We know, we can see these children need support, but actually we struggle to be able to get them while these children are sort of struggling so much.
Daniel, you seem to be nodding away to that. Like, do you want to add your thoughts to that topic?
Just briefly, in school terms, you know, it's about upskilling teachers and upskilling parents. The realities of doing that are very far from the aspiration. So not only do you have resistance, you put on a training for parents, and generally the parents who turn up are those who need it the least and the most enthusiastic. So, you know, the idea from translating from idea into reality is quite the distance, and it's more rare than common to find schools that do it well. So that's actually the realities of how to do it is difficult. And then upskilling teachers, it's not just about upskilling teachers, it's about upskilling teachers in the context of everything else that they're doing. They lead very stressful lives, and there's lots of competing attention from lots of different places for that precious CPD moment. And then, of course, the key question really is what is effective CPD and what does it look like? Those issues that I've outlined there are not really the issues which are being worked on. They're not really the issues being talked about. The issues that are being talked about, oh, it's very important to do it. It's the how that we do it and how we get it to be done effectively is that which is amiss. And actually, I think that schools working in coordination and cooperation with local psychology services such as CAMHS could be a solution. I think that really needs to be thought through very carefully.
I was going to talk about ecosystems, how we get them stuck together and how we could make investments, I guess, into trying getting that system more connected. So I guess if you guys are all experts in different ways, how would you change the how, as Daniel was saying, in trying to identify people earlier? So not the how and how we treat, but how we just do that early identification.
I think for us, for Victoria and I, it's very much early intervention. And when we use the Stormbreak programme, it's primary school age children, you know, as young as we can getting in there, identifying those children that might be raising their head and needing that support. And the programmes that we run, we're looking at primary school age children, but getting in there straight away before the crisis hits. And I think that's the key. And I know Victoria will say more about that.
I know we've got a lot of listeners. I'm sure everyone knows what a storm break is, but do you want to give a 30 seconds on what storm break does and what they do so they understand the context?
Yeah. Do you want me to, Victoria?
Yeah, if you're happy to, Emma.
Okay, so Stormbreak is a children's mental health charity that a storm break is a sort of 5 to 15.
Oh, she's frozen.
I
Go on,
will
take over, Victoria.
Yeah, so a storm break is a mentally healthy movement activity that is between 5 to 15 minutes long. And we use movement as a metaphor for teaching. We use it as a way of teaching distress tolerance skills. But the most important thing about the movement activity is it is topped and tailed with conversations around emotional well-being or mental health. We have 5 mental health concepts, and each movement activity, whenever it's done, will only ever focus on one of those concepts. So it's like we describe it sitting a stone under a drip. If you have a well-being week in school, that's like chucking a bucket of water at a stone potentially. It doesn't really do much to change the shape or form of the stone, but if you have a stone that sits under a drip, over time, the stone changes shape. So we are all about using movement to have helpful conversations, to help the children from a really young age grow up in understanding what emotional and mental health, emotional well-being and mental health is. But also we work with the trusted adults, so the system around the child, the adults that are looking after those children, educating those children, they are all equipped with a common language that enables them to be able to talk to children about their feelings and maybe break down some of the barriers that, you know, some of the stigma maybe around mental health that has previously existed.
Perfect, thank you. I guess Pelumi, but well, anyone of the like, do you have any great examples of interventions or investments or programs that are identifying sort of early intervention and prevention in kind of kids camps? You must have some good ones in kind of in healthy eating, as you were discussing before, Billy.
I think the kind of the program that's most talked about is the Henry program. So it's under 5s. It's a sort of evidence-based group intervention, supporting parents. And if you haven't come across it, it's a very good food program on BBC4 about a month or 2 ago, talking about bringing families together so that they can share their experiences of challenges feeding their kids healthy foods and coming up with ideas together. So that's probably off the top of my head, that's the kind of best early intervention that is happening, evidence-based early intervention that's on at the moment.
Great. Okay, well, we kind of looked briefly at prevention and early intervention, but then let's assume we kind of recognize that someone needs help and we sort of bring them into a kind of care program. Obviously, it doesn't just end there. Like we've talked a lot about kind of the school, and we've talked a lot about the parents in identification. But too often, when someone gets identified, they then think that then goes into a different group of people to deal with, rather than this whole system. So I really want to start digging into kind of examples of connected care and how do you make kind of treatment better. Maybe each of you could explain, like, how does interdisciplinary work in your worlds at the moment? Who are you working with? How do you collaborate with each other around an individual kind of child? Pelumi, we haven't heard from you. Do you want to kick us off on how you see interdisciplinary working around CAMHS?
Yeah, sure. I think it's really important to have all the key stakeholders as well, I guess. So, thinking about parents, schools, GPs, all involved and being able to communicate effectively. I think one of the key problems that we find in that I've observed in CAMHS is the difficulty in communication, or the problems with communication. So everyone's sort of doing different things but not fully sort of sharing what they're all doing, and that's where information gets lost, and of course we we see risk escalate significantly. So yeah, I mean, I think again it's all about improving communication amongst those key stakeholders. That's my view on that.
Cool. And Daniel, like this is your area, right? So what have you seen about how do you get people to work in to build these kind of systems interventions for mental health for CAMHS?
I mean, I've seen good practices, but whether they're replicable on a larger scale is a different question. Just to sort of highlight where part of the problem, just to there's two core issues. One is that the different services, health, social, police, education, they speak different languages. They have different goals and they have different ideas of what to do. So, for example, in education, the idea is to identify as quickly as possible and to make the referral to rush through as many as possible. And in fact, the more you do, the better it is, right? That's not necessarily what CAMHS are seeing and not necessarily what they necessarily need or think. So the language, I mean, I'll talk about language. I'm talking about goals or the way that they work. So they're different systems which don't necessarily work well together. That's the first problem. And the second is that practically speaking, sitting around a multi-agency meeting, I wonder if colleagues here have ever experienced this, but I have seen this many times where it's not officially passing the buck, but it is definitely unofficially passing the buck, where, you know, it's suddenly your turn to speak. And so it feels like this is very much a police matter. And the police will sort of say, well, you know, there's only so much the police can do. This very much needs to be taken care of by the social worker. And then, of course, the social worker will say, this is very much a medical issue. And so we really need to get the medication right. And so we go around the circle. So those two issues, there aren't many good ways of working out those two systemic issues. My suggestion, or the things that I practiced when I was a Senko, was for the various different leaders of the services and for practitioners to really get to know each other. And that meant meeting regularly over, you know, and knowing what each other's ideas were about, you know, priorities, but also speaking to each other in the hall, in the corridor, in the waiting room, getting to know each other, being able to WhatsApp each other if there was a, you know, trying to bypass, you know, one of the issues which schools have is phoning CAMHS and not being able to get through, and yet they feel like they're saddled with something which is tremendously urgent, and in the meantime their anxieties are ratcheting up. So being able to sort of thwart certain things, and at the same time, by doing so, by being in more regular conversation and also in personal conversation, it kind of upskilling everybody to know how each other works. And so I said at the get-go, I don't know how to translate that on a larger scale. I have seen that in good practice in a number of places, not least my own. So that I think the issues are systemic. What I did propose actually, and then I got hit by COVID, that there should be an apprenticeship for leaders of the different sections, society, social work, police, medical, and various other agencies working together, apprenticeship on addressing systemic problems, but learning through that together. And that could be a solution. Whole region solution thinking by being and bringing together different stakeholders and thinking through and making systems, tweaking systems together. But I think that really needs to be done together, not in different silos. Whether that's such an idea would ever take off is beyond my time capacity at the moment, but it's there for the taking if everybody wants to run with it.
I saw a lot of furious nods at the idea that the case meeting can become a bit of a path the parcel rather than a kind of collaboration in the best interests of the person in the center of the case meeting. Is that something that you guys all recognize? And if so, yeah, I completely agree with your solution, which is like it would be great if the team knew each other and had more time to spend with each other. But we have stretched services with not that much time, and people are changing all the time. So how can we solve some of these things? Like, what is gold standard CAMHS? Billy, what do you guys do at Great Ormond Street? Surely that's a kind of the pinnacle of kids care.
I think the challenge with helping support families with weight, it's not really a Great Ormond Street issue. It's actually what they do in their day-to-day life, and it's the support they're getting from school, from social work, from the GP, from all these multiple agencies around who could be supporting the families, and how do we pull them together so we give a cohesive holistic support to families. And it is really time consuming to do this well, finding the right professionals who are involved, getting information to them, to pull a professionals meeting or a team around the family meeting together can take hours of work with a lot of negotiations to get everyone in the room. So it is really hard work. And I think a starting point would be better information sharing, being able to have access to see what others are doing, to see what others have done, and not be constantly scrabbling around looking for summaries from reports from one hospital, from reports from CAMHS, from seeing the GP records. The families can't keep track with all this stuff, and they often come to us completely lost, unaware of what support people are trying to give them. They can't remember what's been told, they can't remember who they've seen. And a lot of the work we often do is try to put that whole story together and be able to see this complete picture. So I think for me, a starting point would just be a better way of information sharing, for gathering that information and helping to form this narrative for this family, and then to be able to sort of share our thoughts back. Obviously, we can meet on the same room in the same virtual space. That would be great. But just as a starting point, some really nice information sharing so everyone can keep track of what's going on.
I promised I wouldn't pitch anything, but on HelloSelf we've built a kind of connected care account for that exact reason. That different members of the care team can come in and see the live outcome scores, all the therapists kind of reporting information, and they can actually message each other and communicate asynchronously around that case file. So that rather than it feel like you only come together once a week or once a month, it can almost feel like everyone's updating each other. It's difficult to get right, but it's hopefully getting there.
I think which is great within one organization. What then often becomes hard is when the people are from other organizations. There's a lot of rules and regulations to stop information sharing, which I'm sure were set up with good intent, but can often cause more harm than the gain, than the safety they offer.
Yeah, I agree. We managed to onboard like the whole community of psychiatrists, because lots of independents can decide to participate even if they're not in the same organization. But it's when the two organizations with different kind of patient record systems kind of clash, it can get quite I'm loving it. Hands up. This is great behavior. Daniel, you want to make a question or a point?
Yeah, so one of the issues which I've tried to tackle in the education system, although it's still a major problem because it's not specific just to education, is that actually education and particularly case files, and I know that Victoria and Emma, you've worked with children who are looked after. So in those good examples, they have files which are thousands of pages thick, and we become information rich and actual knowledge poor. There's only so much information, the school can contain or can absorb. And what we need is less information, but useful nuggets that really help. And it's difficult to communicate what that looks like or what that is unless these agencies speak with each other. So
especially when they're speaking different languages as well, right? So
the typical SEN file or the typical looked after child file, it's hundreds of pages long, and actually that has become detrimental, and what we need is a single page of where we're at, literally the page that we're all on, where we have the most minimal amount of information that has the biggest punch, and I think there's a big trick to that. Unfortunately, we have to contain lots of records and records upon records, and then just transferring lots of data files and everything, and we have to keep them all by law and so on and so forth. I'm not suggesting that we get rid of any of that. I'm suggesting that we would do something slightly different, and that is make sure that the right 5 bullet points reach the right ears always.
Well, we've got a whole conversation about innovation. I think there's lots that we can do by kind of cross-translating these languages using some sort of AI models in order to extract this good stuff. There's lots of fun things that can be done that much. Right, I'm meant to be moving on to kind of outcomes as a theme, but I've got one last question which I really want to ask to Emma. So, because I've got to represent human beings. You all sound very professional and impressive, but I've got friends who've got kids who're struggling, right? And they know me, but it's impossible to navigate the system as a parent, right? Even if you're the most proactive, fighting for it parent, trying to work out where you go, how do you get these systems to join up? So, you know, has everyone got some kind of practical advice that if when a parent comes to you and you're a therapist, like how do you go around getting the team built up around your child? Because even the best sort of clinical psychologists find it hard to try and pull together that organization structure. So how would you go about building a care team around a child?
I was going to echo what Billy said, actually, in terms of having those team around the child meetings. One of the things in the local authority that I'm working for currently, they're trying to move away from is professionals meetings without the parents. So for the last couple of years, it's been a really, really, real regular meetings that we have, professionals meetings, but the parents or the carers aren't invited to that. So the local authority I'm in at the moment are really pushing for, we do not have meetings unless the parents are there, because they need to be listening to the same thing that we're all talking about. They need to be speaking the same language as us. And that's something that we are really, really proactively doing it in the local authority I'm working for, because these parents and the children need that consistent approach from all of those professionals and carers around them.
That's almost like the perfect answer, because I needed to bridge about systems and parents in our next topic. So like, thank you. So let's talk a little bit about outcomes, because one of the things I'm really personally interested in is, do you treat a child as a child, or do you treat a child in a system and in a family kind of system? And how do you think about those two things as different, right? As in, like, how do you treat the individual versus how do you treat the system? But Pelumi, maybe you could talk a little bit about we have a lot of clinical psychologists, counselling psychologists, therapists, and CPD therapists on the line, and a lot of them are interested in like how measures differ between kind of CAMHS and adults. So, like, is there a different set of kind of clinical measures? How do we measure below 18s?
Yeah, there are some differences. So, for example, for young people, we are going to be using the RCADS, which I'm trying to remember I always call it the RCADS. But it's a different set of measures that looks at anxiety and depression, specifically for young people. So you give it to parents, and then you give it to young people as well to complete. So again, that it's one of the changes that we're trying to implement, because of course, as the adult outcomes are completely different. For adults, we use the GAD-7, the PHQ-9s, and the core 10s. But of course, we can't use those same measures. So yes, there are differences. Trying to think of what else would be relevant at this point, but yeah, those are my views on that.
And so if we're measuring in a typical way, we're measuring outcomes, kind of clinical outcomes, and we might be measuring goal-based outcomes and passive tracking outcomes for the child. We're also asking the kind of parents to kind of fill things in. How do we, this is open to the table, how do you approach kind of CAMHS treatment as a system? I think it's great that people are moving towards like not having meetings without parents in the room, but I'm also amazed that I've got lots of people in my ecosystem where the parents have sort of barely been involved in treatment and never had any treatment themselves, where actually I think there could have been a lot of intervention impact could have been done at the parental level. So I guess in Great Ormond Street, like when you're trying to treat a child on sort of with, I guess, food and obesity, like how much is intervention at the family level and the whole system level versus how much is at the child level? That's to Billy, obviously.
I think that down to individualization and where we think the biggest need is. But clearly, there's going to be impacts at multiple levels. The biggest one is that the families we're seeing are often the ones who are most vulnerable to the world around us. The world around us is very obesogenic. It is too easy to put on weight, and it needs a lot of education, motivation, financial savviness, etc., to not end up eating unhealthily. And so right from the start, what we see is the families who end up putting weight are often the ones who are most vulnerable. And it's not the educated, people who can afford, who've got the time, who've got the knowledge to be able to be healthier. So often they're vulnerable, and then we have to think at what level their vulnerability fits in. Is it at parental level, and do we need to offer support from the parents? And almost we forget about the child to think, actually, if we just support the parent with their needs, then actually things will get better by themselves. And the focus needs to be on mum's mental health, or dad's drinking, or domestic violence. And then things will and then the weight will sort of fix itself. So whenever we meet the families, we're constantly thinking, where is the level of intervention? And how do we make progress? We don't routinely have weight loss medications at the moment, but then that is very much at the other end of the scale. This is very much, we're thinking about the system. Often it's when the system is so unchangeable that weight loss medications fit in, and then that is very much about really dampening down appetite for a child. And this is licensed for kids aged 12 plus, and there's lots of things we would do before giving medications or recommending medications, but then very much at the cellular level, and how the hypothalamus is working, you then dampen down the hunger to allow people to not be interested in food in a world around them that is very much interesting and exciting to their brains. So the short answer is we individualize it to get to hopefully aim at the right level.
It is interesting, particularly in your kind of your area, that I can easily imagine that a number of parents come into that system and they're like, this, can you fix the obesity issue over there, please? And finding out that actually the work's going to be happening here with them might be quite a shock to them. Do you find that parents are usually quite proactive as part of that care program, or some of them find it actually a bit unusual that they're kind of having sort of therapeutic psychological interventions when they think that we're meant to be on a weight loss program for their kids?
I mean, it's not always a therapeutic intervention, because lots of practical steps and practical support help mental health as well. But yeah, I mean, some families, find it really helpful and they're completely on board. And some families really struggle to engage with, intervention at any level. And I think often that's just a symptom of the fact that they're struggling, and that trying to change eating habits amongst all of the other challenges they're trying to juggle with isn't possible. We struggle to work with families. So it's difficult. But yeah, I mean, lots of families are very, if you set it up properly, if you set it up as being setting up as to thinking about weight as being a holistic, from society level to right the way down to individual biology and how the cells work, and think about how it's working on multiple levels, and you explain it properly, and you're non-blaming, and you take the blame away from them to the greater society at one level, and to our annoying hypothalamus in our brain that doesn't really want us to lose lots of weight, and you take away the blame, then it's often much easier to work with families, and they can, they see where with the right intention, then hope this usually works to get to aim the intervention at the right level.
Vicky, you look like you're nodding away. Did you have anything to add to that?
Yeah, I think we found that with some of our work in Stormbreak. There was, I was at a Senko lecture and I was guest speaking there. And one of the Senkos has been using one of our tools called Shine in her school, and she'd prescribed a pathway home for a child to do. And the feedback from the parent was, finally, I feel like I am part of the solution rather than part of the problem. And I think, echoing what Billy is saying, if you can remove blame from the parents, and if you can empower them to support the children's needs as they're presented, helping them to understand what is going on for their child in terms of if it's an emotional difficulty, giving them the tools as a gift to help support their child, that's a really powerful thing to do. I used to lead on anxiety at parent workshops. So we used to offer, when I was working in CAMHS, a anxiety workshop for parents that ran over a course of weeks. And I would say around about 90% of the parents that would attend that, it would be for children under the age of 13. we'd have a parent-led intervention. About 90% of the parents would, throughout the course of the program, go, oh, I think the anxiety may be mine. And then that gives you something to work with in the system. You have a parent who's suddenly realized that maybe they've role modeled unhelpful coping strategies, and we've empowered them again by helping them to understand what anxiety is. How do you overcome it? How do you help support your child to push out and learn the skills that they need to problem solve and be resilient with anxiety? So I think it does depend on the family, how you approach them and whether or not they'll receive the help that you offer them. I think removing blame is vitally important, and empowering them and becoming like a partner with them in supporting their children. These are all things that are really crucially important when you're addressing, child and adolescent mental health within the family.
Oh, Billy, hands up, great behaviour. Please interrupt each other. It's good.
And going back to behaviours, I think there's this idea that only psychologically trained people, only mental health professionals deliver psychological interventions. Whereas, I don't think that's the case. I think, lots of professionals can work in a psychologically informed way. So if a family is very insistent that they need to work with the dietitian, then our dietitians are very psychologically informed and thinking about behavior management and thinking about all of the factors that influence how we're eating. Our occupational therapist, for example, she thinks a lot about routines, how we do things, why we do things. That could be done by psychology. Mental health professions can do that as well. But then if you do it from an occupational therapy approach, people find it easier to engage with because it is seen as a very practical solution rather than a psychological solution. Fundamentally, the solutions are often the same. It's just how you approach them.
Right, Daniel?
I think there's a very broad nationwide problem about absenteeism from school at the moment, that it's particularly acute since COVID. I think vulnerable parents, it's very, very difficult. There is no training at all and not much literature for schools. I wrote a chapter or two on this in various of my books and included a bibliography, which is very short, unfortunately. And yet this is one of the big issues of our day. One of the things which we find in schools are phenomena such as parents coming in and feeling very anxious and playing out their own personal trauma from being, in their terms, not very good at school, and finally being old enough to stand up to the head teacher. And so they have a slanging match with the head teacher, and that really has nothing to do with why the head teacher called them in the first place. And this sort of cross conversation happens. And sometimes what also happens is that that the parent comes into the school and feels such a wave of anxiety around, being invited to the school, and then they're not sure what this meeting's about. They're in the waiting room, it's taking time, and eventually get called in, and there's 8 people around the table, and they feel like they're the one who's being judged, and they don't feel like they've got the life skills to be able to cope with this. One of the things which I did just as a simple solution, and I'll share it with you, and it's more that it represents a way of thinking, right? Is that I got rid of the office furniture in my room, and I made my room look like a home lounge. So I literally wanted a parent to feel at home. I made sure nobody waited in the waiting room, and the people who were doing most of the talking were the teaching assistants, who were of the community. They were a similar age to the parents, and they were a similar background to the parents. And this idea of meeting the parents where they are at and thinking about how the parents' journey into the school is something which schools don't do, and yet they hold their hands up saying, why is it that these parents aren't coming to the school? I'm suggesting priority, that we need to think about the journey of parents into the school and how we communicate with them and what they say, and understanding that our most vulnerable parents, and I used to say our most vulnerable parents, but I think it's a heck of a lot more than that now. I'm reticent to use the word epidemic, but it is a very big issue. And so I think that the schools don't have the training. And you know, the training really exists within social workers to be able to support schools thinking about, you know, where these parents are coming from. I'll add just another moment here, just another little thought, which is related to this. You get amazing. I mean, I'm a big fan of teachers and one myself. There are amazing teachers who might be suddenly teaching. You know, they'll have gone to some fantastic red brick university, having done very very well at school themselves, and gone to university, and they did history, and then they became a teacher. And now they're suddenly teaching in this inner city school in London, or in Manchester, or wherever they are, and you know, they're teaching kids from the other side of the street, where they've never really encountered anything like that before. There's a very simple thing that they can do that would completely change a lot of these sorts of things for schools, which is that they can go and actually visit some homes. And they do that with another teacher. There is a method for it, but the idea is they open up both their hearts and their understanding and their mind to where these people are coming from, to be able to see it for themselves. And there is a gulf very often between where teachers are and their training and actually the realities of the people who they're dealing with.
Perfect, thank you. It's actually put time that I'm getting questions on the question, but I'm also getting them sent from the team. One of the kind of questions that came in was actually the panel's point of view on, like, we've talked about measuring outcomes, or psychological outcomes, and kind of treating the system. But at the same time, we live in an academic world that's more about measuring academic outcomes and grading and testing. And you know, does anyone have a point of view on whether this is these are helping each other out, or whether they're conflicting? Do you think our kind of more exam focused, grade focused education system is actually causing some of our CAMHS problems, or not? You nodded, Victoria. Go on, you can start.
Yeah, maybe this is a slightly controversial point of view, but I think particularly post-COVID, we have a cohort of children who have a 2-year developmental gap, which means that they are operating in a world with a 2-year delay in their development because of the social skills that they missed out on, or the academic skills that they missed out on. And through no fault of teaching staff whatsoever, I think the system has not accommodate for that in the coming out and the provision to help support them. So we're hearing time and time again, you know, anxiety in school is on the rise, and how are these children coping in the school environment? But if I kind of fast forward back before COVID, I remember talking to my child's primary school head teacher. So this is a way where I've got teenagers now. And his opinion at that point was, we are just over measuring academic achievement. And we are actually, he made the point that there were some math skills that children just developmentally are not able to acquire until later in life. And they were being expected to demonstrate it in primary school years. So it's developmentally inappropriate. So I think that the system does need a rethink. I am not a teacher. I am not an educationalist by any way, shape, or form. But if you have a system that is making inappropriate developmental demands on a child, it will cause anxiety. It will cause low mood, and it will cause the volcano to erupt because the children just can't contain it any longer. So that's my starter for 10. I don't know if maybe there's others who have an opinion that's different.
Go on, Daniel.
I think this is my field, isn't it, really? I mean, I think there is, you know, we have inherited a libertarian education system whereby what happens is we have 100 children and we grade them according to which is better and which is worse, and let the best ones rise to the top. This education system is far away from where our attitudes, our understanding, our perception of children's development, and what children's needs are, and how education works is. So we are askew, right? We're not actually aligned. There isn't anybody that I've come across in the last 20 years in the, let's say, academic education world, or even the practical education world, that thinks that a libertarian system is preferable. It really isn't. It's old hat. It's Victorian at best. So we are all of us here trying to make up for a system that we've inherited. There isn't a political will to change that system. It's not going to change. Finland changed it, and they did very well out of it. Thank you very much. We can look at it, but the difference is that they were a lot more trusting of their services, and they have a lot smaller society and a lot wealthier society, so they could do it. And there was a simple way that they did it, just to summarize in simple terms. They just trusted the professorial staff in educational training centers to take over the education system and let them do it, let them decide what's best, instead of making it a political item. So yeah, we are stretching and shoving and pushing children through a system which doesn't really work for them. And teachers themselves, they have curriculum outcomes they need to reach. And as a result, they're not able to fully cater for all of the children in the class, and so on and so on. The stress and the pressure is at its heart caused by this concept of libertarian education, which doesn't really work and isn't fit for purpose.
Excellent. I've just been sent a note because I'm losing track of time. So the good news is we're meant to be coming towards the end of our discussion and going into questions, but I've got kind of 2 quick fire questions before we jump into the stream. So most of our kind of listeners are mental health practitioners. They're sort of therapists, right? Clinical psychologists, counselling psychologists, CBT therapists. So let's look at 2 things. Each panel member, we go to hear your points of view. So first of all, there are lots of barriers to this kind of systems level working, right? We all know that as a CAMHS professional, you're not just meant to treat the child, you're meant to treat the system, the family unit, etc. But you're also meant to work out how do you liaise and integrate with all of these different services. Like we're taught it well, like the theory works, is fantastic, but there are barriers in doing that excellently on a day-to-day basis. So like, could you each say here's the barrier that you think is kind of the most broken, and how could we fix it? And then we'll go around the table quickly, and then I want to start getting you guys thinking about innovation, like what could the future look like? But let's try and remove some barriers first. So Pelumi, we haven't had you for a while. Like, what would be your barriers, and what one barrier would you remove, and how would you fix it?
Again, just going back to what I said previously about better communication. I think one of the barriers that we have is the knowledge gap between the parents, parents and guardians, and what the things that they need to do to help children with their mental health. And I do think that if there is better communication, if there's better, and I think Daniel spoke about this earlier, in terms of again, sort of teaching basic skills about how to again, just sort of introducing simple tools. I think that can really make a difference. But also, I think just better sharing of information amongst services, and also sort of parents have easier access to that information. I think that will really make a difference in terms of again, sort of helping children with their mental health.
Perfect. Billy, what would you do? What barrier would you remove?
I suspect one of the potential powers of AI is to be able to condense all the knowledge and information about us into a bite-sized, interpretable bit of information, so that all the records from all the people we've ever seen can be condensed into a helpful summary that is articulates nicely what assessments have been done, what support's been offered, so that the next person who comes along, who's thinking, who is this kid, who is this family, how can I support them, they've got something that a tool that's able to summarize what has been done so far, so that we can then think, how do we add to this, rather than stuck, because too often we reinvent the wheel. We meet a family for the first time and we're relying on them summarizing their life history to us, and we invariably give them a short period of time where we're hoping they're going to tell us the whole truth and nothing but the truth in an accurate way, but that's often challenging for many reasons, and I'm sure it's not intentional. So yeah, a way of, and hopefully AI can do this for us soon, is condensing all the knowledge about us into a way that is understandable and usable. Big ask, perhaps, but that would be quite nice.
Actually, it's not that big. It's a very exciting time. But one thing we've been looking at is in our kind of labs, we've been working on how can we take a kind of summary of a session, but not just summarize what was said, but actually identify what were the kind of therapeutic elements in there and the structures in the conversation. How do we kind of identify risk within that? And then once you've got that sort of psychologically appropriate, how do you present that back to the therapist, but also potentially to the rest of the care team? And they all need slightly different, they need the same information, but sometimes presented in slightly different language because they're using different languages. So the parent wants to get it slightly differently than the psychologist, which is slightly different from what the school might need. And so that you can definitely kind of help in that kind of Babel fish of psychological language and help kind of translating between those. So I like the idea, and we're not far away from it. It's technically possible on HelloSelf today.
But what you're doing is you're doing it for one patient in one therapy session and breaking it down. If you're then doing it for all of these interactions and documentations this person has ever had, and working out how they all interlink and what might be relevant, I suspect that will be the big challenge.
Exactly. I mean, and that sort of systems integration is the challenge. Ironically, it's not a technology challenge; it's a systems and data integration challenge. But yeah, I completely agree with you. We're meant to be holding innovation for the next phase, but I like the fact that you broke your barrier with technology innovation. So thank you for that, really. Emma, what are your thoughts on barrier and your, I guess, most practical tip that you could give therapists in removing barriers?
Well, I was just thinking about kind of in my context as a social worker, the barriers that there's two key barriers, I think, in social care at the moment, and that's that social workers have such a high caseload. They've got a lack of time. And that's massive barrier for collaborative working. I know that I've got colleagues in CAMHS who will be ringing for weeks and weeks and weeks trying to get through to an allocated social worker. And then when they get through to that allocated social worker has left. There is such a high turnover of social care staff, which is a massive frustration. I know it is for other professionals. And the other thing I wanted to say was that the threshold for children either coming into a service in early help in social care or children even coming into care is so high now that by the time that children actually are identified to us, we're not doing preventative work. It's much too late for the family, for the children, for the teachers. You know, we're not getting there early enough. So really, my tip would be that we need much earlier intervention. We need the staff. We need a massive overhaul of social care, in my view, without being too depressing. Because without that, I think we're just going to be continuing this cycle of children coming to us too late.
Yeah, and I like your short, easy tip on how do we fix the system, was we need to redefine the whole of social care. But I completely agree. Like it's very difficult to see lots of small short-term interventions. There are definitely ways that people can kind of build those connections and we can maintain those connections, but it requires a lot of work, right? And it requires work on each of our individual behalves to maintain those relationships in a time where there's just huge waiting lists. I've got a couple of quotes coming in from people going, I love all of this in principle, but like, I'll read some out after we've gone, but I've got another person waiting and I don't have time to talk to people. I don't have time to catch up with my colleagues. And the kind of practicality of doing gold standard care and the is conflicting with the amount of time that people have for each patient. Victoria, what's your barrier and how would you fix it?
Well, Charlie, you kind of made my night when you said that you're finding a way to fix the language barrier, because that would be my number one barrier that I have. So as a children's nurse who worked in CAMHS, I had to learn a new language. And then when I went back to the hospital to work and lead an emotional wellbeing support service, I became the translator between the paediatricians and the nurses and all the other healthcare professionals in the hospital and the CAMHS service, because we speak a different language. So the one tip that I would give to any therapists that are looking to work with children and young people out there is use plain English. Just don't assume that if you're going to use a term that the family will understand it. Apologize if you feel like you're talking down to them or you're belittling them with understanding language, but just speak plainly. Find out what is important to them and help them get there with words and language and metaphors and things that they can understand that makes the whole experience meaningful for them and supportive for them. So yeah, language, just speak English.
It's, I could go very deep and long on this topic, but I won't today. One of the things, not being a psychologist, being a sort of neurobiologist coming into the psychology world, I discovered that there are even languages within the therapist profession, right? Let alone across the different expertise that need to collaborate with around a CAMHS service. But I'm slowly getting there on being a multi-language speaker. Daniel, what would you recommend?
There's something around upskilling staff and giving staff experiences of other settings. I'm sure no one here has experienced the settings of each other's work. I don't know. I didn't ask colleagues if they spent a week in a school, but I don't know if they have. Likewise, teachers don't spend time with social workers or in medical settings. Yet there are people who are continuously working with each other that probably could do with that. I mean, it's not part of the problem there are two systemic problems. One is that we have short-term versus long-term. So any solution which we put on the table here is going to be thwarted by, well, we don't have the time or we don't have the money, right? That's short-termism because we're essentially reactive. What we need is a long-term thinking and an acceptance that certain things are going to take more than a governmental cycle, right? Or even a media cycle, right? So that's the first thing. The second is, and this is just an interesting reflection based on having worked with lots of different countries. It feels to me that, I advise and work with lots of other governments, and they're very much generally open. And here, there's a lot of what we can't do. And I can understand. You spend a lifetime working in education, and you can see the problems, right? And I'm sure that's true in social work and in the medical profession and so on, right? And so it feels to me like we're quite stuck in the mud. And actually, I have to say, I spend my life speaking at conferences and meeting with people who also speak at conferences. And in England, you very rarely hear fresh ideas, really fresh, interesting, different things. I mean, this is an example of it's really nice to hear other professions speaking on the same panel. And that, I think we're percolating interesting ideas. It's more rare than common. And that's why I like this particular event. But I think that we are very stuck, and there is a feeling of being very stuck. It's not very hopeful. It's quite bleak. And actually, I think this is an atmosphere around most of our services. Now, I don't know what you put it down to. I can't say this is the political state of affairs. It's not my remit. I don't get it. I don't know the causation. But I'm really interested in what other countries are doing. And I think taking collective time out to see what are good practices in other countries and how we can import those to England and getting fresh and innovative ideas, that would be a good starting point. At the very least, sort of get us to reflect on what we're doing and get us to look up. It feels like we're looking at our own feet all the time, and we don't have sort of vision and zest for this. Like it's, as I say, I come back to that word bleak. It feels like it's not a hopeful. I don't feel hope in this question for England.
Okay, well, I'm sorry. I'll be more hopeful with my next question because, although it's a very difficult topic, there is so little we know. Right, there's so much more to discover about how we can build kind of mental health in our youth, and so I'm actually quite hopeful that we can have sort of systemic wide impact, but it does require looking around the world and thinking quite differently about it. It can't just be more people going through the same pipes. Oh, sorry, Billy, you put your hand up.
I didn't realize I did. Sorry.
Okay,
Whilst I'm speaking, I think we all did a big one last week. So hopefully that was a relatively small change. It can make a big difference with the new government.
Exactly, exciting times.
That's one thing. And secondly, one thing I'm slightly fascinated why I never ever, pretty much never ever, get copied into any correspondence from CAMHS. And I'm not quite sure where the philosophy is that. And one of the big shifts we did recently is when all our records went electronically, is we reformatted the way we wrote our notes so that we would take notes in a format that was shareable so that other people would hear what's going on and hear our formulation, and we would share it. And it is pretty much common practice within the medical world. We share our thoughts, our formulations with other professionals working with the family. But for some reason, that doesn't seem to exist from mental health professionals. And we next to never hear what's going on. They seem to work in a silo. And it could be a fairly simple solution. You guys are asking about what networks, who are the networks for these families. Why can't you share more information?
Maybe we should onboard all the medics to the HelloSelf connected care platform, and then we can all talk to each other. And I know I'm meant to be a chair and therefore not allowed to have opinions, but there's some really interesting stuff in this space. I mean, I think the biggest thing we could do, speaking to lots of I speak to therapists all the time, right? And CAMHS therapists think, okay, it's my responsibility to treat this person and to make sure it's kind of connected, and I've got to work with the system. And then you speak to the social worker, and they're like, it's my responsibility to look after this kid, and then I need to make sure they're connected to the system. And they're all working really hard, and they're all trying to work out how it connects, and it doesn't really glue together. And I speak to loads and loads and loads of parents who are all the time going, it's just impossible. Like, I can't work out how to do this. It's so hard. I think if we could get parents to realize that the first thing they can do is like build your team. Like, what's your team system? And so they kind of understand, I need a social worker, I need my teacher, I need a therapist, and I need to be the person who makes sure they link up. I think we could get there much faster. But at the moment, parents kind of are terrified. Like, they're just so scared because their most precious thing is struggling, right? And it's emotionally very difficult for them. But if we could somehow empower parents to be the kind of the glue to this system, it could be great. But that requires quite a lot of systems change, because it's hard work for the parents to make sure the cogs are well oiled. Right, so we've got some questions coming in, but I do want to talk about innovation as well. But let me read out some of the thoughts. Lots of appreciation for the thinking. I think Daniel's points regarding the systemic approach and familiarity with each clinician is great. However, having recently worked in CAMHS, setting my diary was in a CAMHS setting, my diary was booked out every minute of my working day. I did not have enough time to visit the toilet without missing part of my meetings, let alone chat to colleagues in the corridor or share a cup of tea. We've collectively become stuck trying to keep pace with our workload, and one of the sad sacrifices is that kind of getting to know our colleagues is being lost. How could we kind of bring that back? Lots of kind of that kind of sentiment. Lots of sentiment about, I totally agree, simple English and cutting the jargon could really help. So there are definitely people listening. Let's jump into innovation. We'll ask some of these questions while we're at it. We talked a little bit about tech in the future. What does everyone think that a CAMHS service in, let's choose an interesting date, 2035 looks like? And then we can talk about whether we've solved climate change and global poverty after that. But what does the CAMHS service look like? Daniel, do you want to go first, as you're looking like you're thinking very hard about that topic?
I was just reading one of the questions, so actually I didn't really.
Okay, don't worry. Well, Pelumi, do you want to kick off? What does the future look like?
Yeah, sure. I'm one of those people. I do really actually, think that AI is a positive thing. That I do think AI is going to be quite a key part of our world. So thinking about the future of CAMHS, and as a therapist, I think about the possibility of basically having more time to do. Having more time for communication. I was going to say having more time to do more sort of the more important stuff than sort of some of the, I guess, slightly more boring admin. So I think, if AI can be incorporated into into our systems to help summarize our notes, similar to what you were saying earlier. I think that that would be really helpful. I also think that again, just having better communication. I would like to see that. I would like to, I would like a situation where we were all sharing maybe even if it's not a similar platform, but platforms that can communicate with each other, and also again just better tools for clinicians to record progress, but again in a way that is more efficient. Again, going back to what you were saying, Daniel, where we're not there's less, it's less of just writing stuff, but actually more more about capturing the important information and just having it there for everybody to see. I think, yeah, that's what I would like to see personally.
Perfect. I'm gonna start mashing it up, I think is what they call it. I'm going to start asking questions and asking people to answer them in an innovation way. So here's an interesting thought, which I'm going to ask to Victoria, because I think her answer is going to be an innovation answer. If I'm wrong, you can tell me, Victoria, that it's wrong. What are your thoughts on advocating for more problem-free talk and strength-based approaches across various contexts like schools, etc., to support young people's mental health more proactively? Well,
as a positive psychologist, I think it's the way to go. I think if we can educate children and the adults around them in knowing that, we have the tools within our gift to thrive, we can activate them and use them. I think using that kind of language is more empowering than a deficit type of model. I think it promotes protective factors. I think it enables the children to define their self-concept and all of these things that we know were really beneficial in protecting mental health into later years and thriving through life. So I think we should be doing it. A lot of Stormbreak language, if you go and check out the website, not a shameless plug, but it's just an example of how we use language to normalize emotional difficulties and mental health, how we use the systems around children to encourage them to know, I have some gifts and some abilities and something that I can bring to the party that is of value and worth. Doesn't mean I have to be the best at everything. So it really helps children to be comfortable in who they are, which again protects from anxiety and other sort of mental health difficulties as they get older. So I think bring it on. We've lost Daniel.
That's right. It was a good answer. He's not appalled by your answer, I'm sure. He was thrilled. Anyone else have Emma or Billy? Do you have any innovations? And if not, there's a lot of questions coming in all of a sudden. Everyone's waited to the last 10 minutes so we can dive into those. But what would be your innovation for the future? What does the service look like in 2035?
CAMHS, I'd probably that it doesn't exist as an entity.
I find it extremely strange that we draw an arbitrary line, and there's this horrible thing that people get up to an age on one waiting list for a year, and then they haven't been cleared, so then they go to the adult and they join the back of the queue again. I mean, surely that's a very easy problem to solve, in the next 3 months.
There's also this concept that emotional support is only delivered through CAMHS, whereas at the moment CAMHS is just the tip of the iceberg. Nowadays you have to be incredibly unwell to get into CAMHS, and actually a lot of the support for emotional well-being is often happening outside the CAMHS setting. So yes, it doesn't exist. And also can I just add something to the problem-free talk? Lots of people often ask me why I spend so much time in problem-free talk, but it's fascinating the stories that you hear when you're not talking about the problem and the dynamics, and then how the families interact with each other and how they explain things. And suddenly, if you're used to doing this problem-free talk, you hear about not from the words they're saying, but the way they say it, the way they interact. You hear so much about their lives and the way they think and the way they feel by having a very holistic, problem-free talk with families.
Yeah, I think it's a really interesting space. Oh, you're back, Daniel. Welcome. Emma, did you have anything you wanted to add? And then I'll jump in some questions for the last 10 minutes.
Very similar to everybody. I would like it not to exist, but it is here. Much more multidisciplinary teamwork, I think, would be really, really key for me. Having educators, social workers, nurses, doctors, all in CAMHS, all working together. would be a much better holistic approach for children's mental health in a nutshell.
Perfect. So there's lots coming in. So I've actually got two streams of questions. So I'm going to jump around. I'll answer this one extremely quickly because it sounds like it's aimed at me. So what's Hello Self plan in using technology and AI to support children and young people in their mental health and well-being? So the short version of this is we've done a lot of work on understanding kind of permissions to make sure that kind of we can treat a family and kids as a single unit. And as you're talking about like joining up notes, etc., we want to understand like even if it's different treating clinicians doing a parent and doing a child, we can bring that system together. So we've done quite a lot on that space already. We've obviously done a lot on how do we help people practice what they learn in the therapy sessions in their lives. Actually, kids are quite good at using kind of technology as kind of, I mean, 13 plus kids are quite good at using technology as reminders, and they're using it sort of quite negatively at the moment. So how can we kind of use technology to deliver behavior change off devices? And then particularly about AI and not wanting people to deepen ongoing problems of spending a lot of time online. I think the most interesting thing that we can do in the short term with AI is give children, young people, but also adults, everyone, the ability to reflect on what they've learned in that session in a kind of conversational way, where you can actually have a conversation almost with yourself about what you've learned on that platform and what you learned about that session, because that positive reinforcement can give people a private place to have a conversation about the context of their therapy. So they're the kind of three big things that we're looking at the moment, and all of those could be innovations that we could deliver within sort of 3 to 6 months. My questions for you guys. What can we do to support the mental health of non-verbal children in special schools? Is there anyone with expertise on this and or can signpost on where they can find good information? Anyone good with non-verbal children?
I used to work in a school for children with PMLD, and I don't know if Daniel has any suggestions as well. But we used stories, movement stories. You know, we've got Stormbreak activities that I've used with children who have profound and multiple learning difficulties as well. And it's just about engaging them, about talking to them. So we've got one called Cross Country Running, and you tell it like a story, and you get them to move their arms with you, and you narrate the story for them and the feelings like, oh, look, there's a puppy, you're feeling happy. And it's that kind of, it's making the movement and the conversation accessible to their developmental age in an appropriate way. And you can still narrate their experience. So that's how I've done it in the past. I don't know if that answers the question.
I think it's well. Anyone got any sort of things they should read? Any references? Any good place to find information on that topic? We'll find someone, share it in the links after the for those who are watching it not live. Right, we've only got a few minutes, so I'll keep rattling through these. How can social workers and psychotherapists work together effectively when it comes to working with or supporting children and young people and their mental health? Often at times it can feel like social workers and therapists hold opposing views and have poor communication channels between them. Do we find that there is often a conflict between a social worker and a therapist? Maybe we should go to Emma for that one.
Yeah, I think I totally agree. I totally agree. I think we've talked about so much in this call is about communication, effective communication. I also really like we were talking about earlier. Billy was saying about having a real short summary, you know, getting that information and being able to be happy to share information. We need to be sharing information quickly and effectively, and that's where I think we all, it's not, you know, it's not blameful, but we all fall down a little bit.
I was smiling not because I disagreed with your answer, but I think we keep losing Daniel in great poses. But I think Centre Parks' Wi-Fi is giving up on you, Daniel.
It is. I have to go. Thank you, everybody. I've really enjoyed this, and kudos to you. Thank you very much.
Thank you for your time, Daniel. Right, if the others can stay for the last couple of minutes, I'll ask the last two questions. But thank you, Daniel.
Can I just come in with therapy?
Of course, yeah, go on. Billy,
I think
please.
part of the challenge is depending what type of therapist you go to, or either by professional or by individual, they might come up with their own hypothesis or of what the problem is and how to fix it. And it's not always, some of the fixes to the problems are often complicated, and it's not clear who's got the right answer to the fix, if anyone has it at all. And I guess that's part of the problem, isn't that? Do you trust their opinion? There's often quite a lot of, particularly with weight, and the families we see, and just coming to not, we often have disagreements about what the fix might be or what support the family might need, or trying to agree on the level of risk. And fundamentally, it's about professional opinions and whether you agree or don't agree with them. And that's often a challenging thing, because different types of therapists are going to disagree with each other often. So I guess partly is, how do you get the right diagnosis and the right therapeutic advice?
And also, I think the threshold of risks is very, very different, isn't it? So we'll often be challenged by professionals where they'll say, you should have acted earlier for this family. But actually, the threshold in social care is so high, and it's not right, but it's so high that there then becomes that kind of argument, doesn't it, that opposing views.
And mental health is kind of structured around conflict anyways. It's so based on kind of opinion. Like, it's not like you can say you've got a broken knee, you haven't got a broken knee, right? So if you ask 5 different clinical psychologists, you might get slightly different answers. If you ask a clinical psychologist, a counselling psychologist, a psychotherapist, a CBT therapist, you'll get different answers. And then once you bring the whole spectrum of different carers around that individual, you can get huge different answers. And I guess it's about how do you create the space for both challenge, but kind of collaboration in creating a kind of united care plan, which is definitely not easy to do. Right. Well, I've got 2 last questions. One's from me, one's from a very practical one. So any views so far on the implementation of, this is a perfect one for your Stormbreakers. Any views so far on implementing of mental health support teams, working closely with the schools to raise awareness of emotion and mental health from early age, as well as supporting schools with early identification of mental health concerns? So has anyone seen the impact of mental health support teams in schools?
Yes, we're working with mental health support teams in London and in Dorset to help roll out one of our Stormbreak programs called Shine, which I mentioned earlier. I think they have a great impact, but unfortunately, the need that you need to have to be able to access them is still too high. And I think there's just not enough boots on the ground. It's such an early service that's being developed. I have hopes to see the service develop further, maybe in the next government. But yeah, there's just not enough boots on the ground.
It's a beautiful bridge, because I do believe that the next government has kind of committed to putting more kind of mental health support teams in schools. So
I hope you mean current government, and you're not already.
Current,
they're going to be called the next government. Yeah, the current government as of a couple of days ago. In fact, it was quite exciting. I think there was the reappointment of the speaker and stuff today. Yes, the current government. Okay, well, speaking of the current government, let's finish as no one can do anything not talk about politics at the moment, because it's so exciting. Let's do really quick fire round around the table, starting with you, Pelumi. What advice should we, if you could give one piece of advice to our new sort of boss, Wes Streeting, what would you be suggesting that we do for the mental health services in the UK, specifically around CAMHS? What would be your one investment? So Billy's gone, oh no, that's a big question. How do I finish on that? At least you get a few seconds to think about it. I'm throwing Pelumi under the bus first.
I would invest in more education. I think that, again, education is key. Education, especially at the for parents, for all the key stakeholders, so that, again, there's just better understanding about the mental health needs of young people, and what not to do, as well as what to do, but also what not to do that could potentially make things worse.
Perfect. More mental health education in schools. Emma, do you want to go next? And obviously, you can say they should put storm breaks in every school, but on top of putting storm breaks in every school, what could it be?
Much earlier intervention, lower thresholds, so more staff, more money, so our thresholds for services can come down, and much earlier intervention, and echo what Pelumi said, more education, and storm break in every school.
And Victoria?
I concur, storm break in every school. I would, I didn't actually say it in the innovation question, but I would love to see CAMHS go out of business. And I don't mean that in a terrible way. I just would love to see the need for CAMHS reduced, so that mental health emotional well-being promotion, improving emotional literacy in our children, and promoting distress tolerance skills, I think would go a long way to, if we invested there, we would see the need for CAMHS services shrink.
And Billy.
I think it's to ensure that we remember that mental health difficulties are often the final result, not the starting point, and how it's often a combination of difficulties with peer relationships, social media, school, deprivation, poor housing, all of these things add up, and that the sequelae of these is mental health. So thinking that reassuring the government that ensuring that improving all these other aspects is also going to improve mental health. And the money to improve mental health doesn't just have to go into mental health services itself. It's about thinking about how we improve society so that our well-being improves along the way.
Well, so thank you, everyone. No one asked my opinion, but controversially, the non-psychologists, I would say we should spend more money letting kids in schools spend time in green spaces and eating much better food. I think if we can do those two things, you could have quite a big impact on short-term mental health benefits. Obviously, we need to put a lot more money into prevention, treatment, and post-treatment prevention, but hopefully those things can happen soon. It's been an absolute pleasure. We've actually run over on time. I haven't actually answered all the questions, but we can follow up with some of your answers afterwards. Only 4 minutes over, but I hope everyone really enjoyed the content. Thank you all to the whole panel. This will be recorded. Well, it has been recorded. We'll be sharing it amongst the HelloSelf clinicians. If anyone else wants access, they can email the HelloSelf team at hello@helloself.com. We will be doing our next CPD session next month. So thank you all for your time, everyone, evening, and have a wonderful night.